Hello everybody. I am very happy today to meet all of you in this lecture. Today we will talk about angina. As we know, in case of angina, patients present with chest pain, cardiac chest pain due to ischemia. Angina also usually caused by atherosclerosis, that is mean ischemic heart disease. Less commonly due to valve disease such as aortic stenosis, arrhythmias, hypertrophic cardiomyopathy, anemia, or coronary vasospasm, for example cocaine-induced. Angina affects 1/10 over 65 years old. Commoner in men. Signs and symptoms of angina. Firstly, intermittent, stable chest pain with three classic features. Number 1, on ECG, exertion is precipitant. Number 2, constricting discomfort of anterior chest, which may radiate to neck, shoulders, jaw, or arms. And last one, GTN, or rest, provides relief within 5 minutes. If all above symptoms present, 3/3 equals typical angina, 2/3 equals atypical angina, 1/3 equals not angina. In investigations, there's basic tests, bloods, full blood count, rule out low hemoglobin and anemia, urine and electrolyte, comorbid chronic kidney disease, assay baseline, and cardiovascular risk factor. Also investigations, including blood pressure, lipids, and glucose. ECG, often normal, but may show ischemic changes, Q waves or street T changes. Diagnostic testing for ischemic heart disease should be offered to all those with typical/atypical angina or an ischemic ECG. Connecticut coronary angiogram is first line. Functional imaging using stress agent, if non-diagnostic, stress echo plus exercise or dobutamine stress, myocardial perfusion scintigraphy plus adenosine, dipyridomoly, or dobutamine stress, or Mr. perfusion plus adenosine or dipyridomoly stress. Invasive angiography, if functional imaging non-diagnostic. For those with known ischemic heart disease, for example previous MI or angiography, hence not co-indicated with chest pain of uncertain cause, consider functional imaging as above. Exercise ECG. Note, this is not recommended by NICE for initial diagnosis of ischemic heart disease. Is there any question before the end of this lecture?
Thank you, Dr. Ahmed Dr.abushama. I have one question, please. How we can manage patients with angina?
Okay, good question, Khalid Farag. There's 3 components in management of angina patients. First, the antianginals, first line, beta blockers and or calcium channel blockers. Use both if one is insufficient. In second line, isosarbiturnonitrate, ISM, nicorandil, K plus channel opener, ivabradine, if channel blocker, or ranolazolate, N plus channel blocker. Can be used as monotherapy or in combination with first-line drugs. Consider revascularization if not controlled by chew drugs. PCI for 1 or 2 vessels. CABG for left main or triple vessel disease. Both relieve symptoms, but only CABG reduces mortality. Short-acting nitrate, GTN spray or sublingual tablets. Used before planned activity and when symptomatic. If pain continues for 5 minutes after first dose, call ambulance and take second dose. Side effects of nitrate: headache, flushing, and light-headedness. Lastly, cardiovascular disease prevention, aspirin for all, clopidogrel second line, and consider statins and assay. Lifestyle changes, through simple advice or as part of cardiac rehab, includes exercise, healthy weight, stop smoking, and Mediterranean diet. Exercise should be for 30 minutes per day, but below anginal threshold. Thank you very much for listening and attention.
Thank you, Doctor, for this nice lecture. What is next topic, God willing?
Next topic, we will talk about acute coronary syndrome, God willing. Thank you.